scientific evidence behind using DCB?
In bifurcations, I think that DCB nowadays are a must.
Once you come out with 2 DCBs, not putting a stent in a critical bifurcation lesion, the amount of satisfaction you get, that's entirely different.
We tried one Sirolimus eluting balloon, but it was easy to cross, but it was not effective. Patient kept coming back with target lesion failure. And I've tried different Paclitaxel balloons, and some of them were performing very well in the long term, but in the short term I had distal embolization, which is, I think, a major problem.
Yes, though DCB is with us for a long time, but in future we'll have a very good outcome with these DCBs. So, good morning, Dr. Florim. So, we have got a Dr. Florim with us. He's one of the renowned interventional cardiologists from Switzerland, and he has got a vast experience as far as use of DCB is concerned. So, we'll be talking about the use, the indications, and the present scenario of DCB in the interventional cardiology. So, Doctor, what's your take on use of DCB in interventional cardiology in 2025?
Ankush, thank you so much for this opportunity to speak to you about this. I think the DCB is like a train which is running, and I always tell to younger colleagues and also to older colleagues, the train is running, so hop on the train, because this is not going to stop. Now, I've been using DCBs now for some years. We participated also in some trials. Interesting enough, in the last, I would say, 5 to 7 years, the speed of DCB use and also the indications have widened. And I think they have widened because there's many reasons for that, but one of the reasons is because stents are not perfect. So DCB use is increasing because it helps us in our daily life.
What is your take on vessel preparation before giving DCB to that vessel? Is it different?
It could be a bit different, because I think with DCB the goal is to achieve lumen, but not to create a big dissection which forces you to implant a stent. And if you intend to implant a stent, then the dissection size does not matter, because you will put in a stent and then it won't matter, but with DCB it matters. So I think sizing becomes a bit more important in lesion preparation, and also probably the use of scoring and cutting balloons becomes more important, because this allows you to gain lumen without creating a dissection. But we are all in a learning phase still. Even people who have done DCB for some years, they still struggle to predict which case is really still doable with DCB and where we still need stents.
So, what are the areas where you will, look at? Okay, I'll be using DCB in this case. For example, my case scenario to you. Let us suppose you are seeing some LED lesion. So, how will you start? You do imaging, you cut it, you put a DCB. How you will size it? So, tell me your take. Okay, these are the vessels where I'll use DCB, and how you will proceed for the case.
So I think first, maybe if we go with the indications, then I truly believe that we should be using DCB where we expect that stents are likely to fail or not to offer optimal results. This means bifurcations, so avoid two-stent bifurcations, highly calcified
Side branch in bifurcation.
Well, sometimes, maybe you can even do both branches, but very often you are right, you will do the side branch. Highly calcified lesions, long lesions, diabetic patients, also in-stent restenosis, despite the new guidelines which now suggest different, but I think still there's a lot of room for discussion in ISR. And of course, small vessels, where we have some really sound evidence that DCB work. Now, I think when you prepare the lesion, very often you will maybe achieve a good angiographic result. The result doesn't have to be perfect, because while in the stent world your result should be perfect or nearly to perfect, I think in the DCB era you can accept a suboptimal result because this is likely to improve.
And what is the definition of this suboptimal result? Well, let us suppose you have got a proximal LED. 90% disease, and you have decided, as per your understanding, I am going for DCB in this case. How you will proceed? You'll do image. What's your? How will you do this case?
I do imaging in almost all patients, and
So imaging is one.
So imaging is one for me, but I think imaging is mainly important in the learning phase. I think DCB should not become a slave of imaging. Imaging is nice, it's good. I am a big advocate of imaging, but I think it should be also possible to do without imaging. So if you use imaging, then usually you do the imaging and you check for two things: plaque characteristics, so calcium, fibrosis, soft plaques, and you check for size. Because, I think size is very important, since you will choose maybe your cutting balloon according to the luminal diameter, reference luminal diameter, instead of vessel diameter, which is different now maybe to the stent world. And then after your lesion preparation, you look at the result. Now, if you go with imaging, then you will look for two things. First, you need to have enough lumen, and I think in the proximal LAD, probably you should get more than 4 square millimeters of lumen, which is going to likely increase to 6-7 within weeks.
With positive remodeling.
Absolutely. And then the second thing is also the absence of a major dissection, which is forcing you to think of stent implantation, and also very important, the intramural hematoma.
Yeah.
Especially in vessels which are not calcified, intramural hematoma can happen with cutting balloon use. So I think there you want to be sure that if you have a hematoma, then either you cut it again and relieve it, or you stent it.
So what are the areas where you will think, okay, I have planned for DCB, I have done this, no, but this is the time I should put a stent? The most important indication. Intramural hematoma?
So intramural hematoma, if I cannot cut it out.
Or flow limiting dissection.
Flow limiting dissection, and then of course if my strive to get luminal gain is not sufficient. So you do all your work, and your diameter stenosis is still over 50%, I think in those cases, I don't hesitate to put a stent, because, stents still work fine. It's not that we should risk the safety of the patient and not implant the stent. But where we think, we have a reasonably good result, then use DCB, because this is going to be better for the patient in terms of, even having a patient who will not be forced to use antiplatelet therapy for some months.
It's very important.
Because, we have sometimes patients, they need an operation very soon.
Yeah.
In those patients,
yeah. So I think that we need this answer, like imaging endpoints of DCB. As you rightly said, maybe 4 or 5. I think this is the answer that we require in future studies. So, Dr. Florim, what is your choice of DCB, Paclitaxel or Sirolimus coated balloon?
The real answer is that there was some negative noise about Paclitaxel some years ago, but that noise has vanished.
Yeah.
And so that noise switched many operators to Sirolimus, and I was one of those also leading towards Sirolimus. I have made good experiences actually with both balloons. However, I think at the moment, I believe that also after recent publications where Sirolimus did not perform very well,
yeah.
I am again more on the Paclitaxel side, and I think there are quite a few studies now coming, and we'll see how these results are. At the end, we need data to answer this question, but at the moment I'm pro Paclitaxel. How about you?
So for me, if I want to use DCB, Paclitaxel is the answer, because I go by evidence, and recent that TCT data that they clearly showed that Paclitaxel did better than Sirolimus as far as long-term outcome is concerned. So my personal feel, and as well as a bit of evidence, I think Paclitaxel is the answer if we want to go for DCB. So do we have scientific evidence behind using DCB to support DCB use in present scenario?
And I think we have a lot of evidence. I actually, before this talk, I checked ChatGPT, and I said, show me the evidence of DCB in coronary disease. And there is a lot of studies. And these studies are not new. I remember we participated in Basket Small, which was a DCB small up to vessels of 3 millimeter. And this was when 2012 we were recruiting, so the therapy has been there for a long time. This was a positive study. So there is a lot of evidence, maybe not the evidence we want in very complex lesions, because the evidence has been created in small vessels and in ISR, but we don't have a lot of evidence for the indications I said, like for diabetes, for highly calcified lesions. But we know that in these indications, stents don't perform well.
Yeah.
So that's why I think it's good that we elaborate there and we go into that field where we solve a problem and don't create a problem.
I think in present scenario that the scenarios where we know that our stents are going to fail, these are the areas we must use DCB. So what's your take on use of DCB in bifurcation lesions?
In bifurcations, I think that DCB nowadays are a must, because what you should not do is to put two stents, because although it looks good in the acute phase, and I'm sure many of us do a fantastic job, take a lot of time, use a lot of gear to achieve a good result. But in the long term, when these patients come back, very often the result, especially in the side branch, is not optimal. So I think avoiding a stent in the side branch is important when using a DCB, and we have now also a good evidence for that. However, I dream to maybe use two DCBs for a bifurcation. This is the ideal scenario, but very often this is not possible, and I'm happy with only one stent and one DCB.
So I have done around 16 cases of bifurcation, two DCBs.
Okay.
So once you come out with two DCBs, not putting a stent in a critical bifurcation lesion, the amount of satisfaction you get, that's entirely different. So, Dr. Florim, what is your opinion regarding use of DCB in a long calcified vessel?
I think in a calcified vessel is really something I love.
Do you think that in calcified vessel you can modify and place a DCB and come out, and do you expect a positive remodeling in these vessels?
Very good question. I think if I can put it like this, if you have a circular calcium and you crack it, you will create, in the cracks you will create space. You will have growth of tissue within this space. That space will widen and will push the calcium blocks away, so the vessel will become larger. If you have eccentric calcium, very often, and you don't crack it, sometimes you cannot crack it, but you use a cutting balloon, for example, then you will have vessel growth on the opposite side. So I truly believe that in calcium, you can gain lumen. Now, do we fear dissections in calcium? Yes, but they matter less, because in a calcified vessel, the dissection will only propagate to the next calcium block and then it will stop.
Usually they are stable.
Yes. So I think that's why calcified vessels are actually ideal. And stents, opening up stents in calcified vessels is difficult.
Yeah, that's a very important point. In calcified lesion, as it is, the outcome of stent is not great. And if you're getting a good luminal gain after modification of calcium, maybe by using orbital, rota, cutting, or IVL, and putting a DCB after that will be a great choice. So
we should, we just recently treated a patient here in India, and we did orbital atherectomy for a very long time because the lesion was very difficult to cross. But once we crossed it and inflated an OPN balloon and cracked it, it looked really good and stable. So I think had we used a stent there, it would have been not a very wise choice, because we already had the lumen. We did not have a dissection which was flow limiting. So I think with DCB, we get away and we make things less complicated.
So do you think that all DCBs that are available, they are same? And do you prefer some DCB or some technology over another?
That's a very good question, Ankush. And I've been trying now almost all DCBs which are on the market, and not many of them are still on my shelf. The reason being that we tried one Sirolimus eluting balloon, but it was easy to cross, but it was not effective. Patient kept coming back with target lesion failure. And I've tried different Paclitaxel balloons, and some of them were performing very well in the long term, but in the short term I had distal embolization, which is, I think, a major problem, especially if you treat patients who are stable. You convert a stable patient to a STEMI for at least for some hours. So at the moment, I think we should really be careful which DCB we use, and we should test this DCB one by one. As there was no class effect in stents in the early generation, I think also with DCB there's probably no class effect. So I think we have to test them. We have to bring this patient back. We have to do our regular work. So in our center, all patients with DCB treatment are in a registry. So we get prospective a registry and the follow-up of these patients. So I think the question which DCB is the best, for that claim we need data, and at the moment we don't have data, although we are now preparing a trial to compare the Protégé and versus the Boston Scientific's balloon agent and stents. So I think that study will give us some good input. What is better? So far, I think for Protégé, I've been using it now since 2 months. I'm very happy with the results because it crosses well, it doesn't embolize, and I can also see the particles on OCT. So, so I think that's encouraging, but let's see the long-term data.
So how do you predict a good long-term outcome when you are using DCB? Okay, this is the case, I'm using DCB, and okay, these are the things I should see in this case, and patient will have a good long-term outcome. 1, 2, 3.
So I think if you use intravascular imaging, then you should clearly see some dissections, because the dissection are entry points for cells to give you lumen. If you don't have dissection, then it's going to be very difficult to expect lumen. That's the first thing. Second thing, you should have some lumen, because of course you can gain lumen, but if you start with 2 square millimeters, then don't expect 10. This is not going to happen. But I think if you gain 5, then you can expect 8. So I think this is exponentially increasing. So that's why you should have some baseline lumen post PCI to expect some more lumen in the future. And third, I think, which is very important, is to really have a good flow at the end of the procedure. Because if you treat a long vessel and like in a CTO, and at the end you don't have a good flow, then this is not a good sign.
I think, again, as you rightly said, that imaging is very important. Do you have any choice over OCT over IVAS or IVAS over OCT as far as DCB use is concerned?
In DCB use, I am 100% OCT. You know that.
Yeah. Why I asked you this question, because, as you rightly said, one of the indication to go from DCB to stent is extension of dissection and intramural hematoma. So that is what my feeling is. When you aggressively preparing your vessel to have a good long-term outcome with the DCB, I personally feel that IVAS is the answer. You can see crystals very well, you can see the luminal gain. Here, nevertheless, thanks Dr. Florim for giving us a great insight about the use of DCB in present interventional cardiology. And I strongly feel that yes, though DCB is with us for a long time, but in future we'll have a very good outcome with this device.